Today on the deep dive, we are walking straight into the diagnostic muddy waters of clinical chemistry.
Yeah, the really muddy waters.
Seriously. And look, if you're prepping for your ASCP medical laboratory scientist board exams right now, in that final stretch, consider this your ultimate survival guide.
Absolutely. I mean, we aren't just memorizing flashcards today. We're figuring out the underlying why behind the chemistry. So you become basically bulletproof on test day.
That is exactly the mission because, well, the board examiners know that rote memorization kind of fades the moment you walk into the lab.
Right, it vanishes. But if you understand the biological mechanisms, like why a specific enzyme acts the way it does, or how an instrument physically manipulates light, you don't really need a mnemonic.
Yeah, you just logically deduce the answer from whatever wild patient scenario they throw at you.
Exactly. You just work the problem.
So let's map out this whole biochemical landscape. And I want to start at the absolute foundation, which honestly gives a lot of people a huge headache, the numbers.
Yeah, the dreaded units.
Yeah. Right. Specifically, the shift between conventional units, which we're used to seeing in older textbooks or U.S. hospitals, and SI units, the System International. It's not just moving a decimal point.
No, not at all. We're talking about completely different ways of measuring matter here. It's the transition from measuring the physical weight of a substance in a fluid so mass per volume, like milligrams per deciliter.
Okay, mass per volume.
Yeah, to measuring the actual number of molecules in that fluid. So SI units use molarity, which is moles per liter.
Gotcha. Let's anchor this with the heavy hitters, the ones you absolutely must know. For total bilirubin, the conventional range is 0.2 to 1.0 milligrams per deciliter.
But in SI units, that becomes 3.4 to 17.1 micromoles per liter.
Right. And then blood urea nitrogen, or BUN, shifts from 6 to 20 milligrams per deciliter down to 2.1 to 7.1 millimoles per liter.
And you've got total calcium, which moves from 8.6 to 10 conventional over to 2.15 to 2.5 millimoles per liter in SI.
Wait, and fasting glucose too, right? That is arguably the most tested conversion.
Oh, 100%. It shifts from 70 to 99 milligrams per deciliter to 3.9 to 5.5 millimoles per liter.
And we also need to keep an eye on total protein, right? That one transitions from 6.4 to 8.3 grams per deciliter, simply to 64 to 83 grams per liter.
Yeah, that one is basically just a factor of 10.
Okay, but stop right there, because this is where my brain starts to hurt. Why do these shifts look so completely different depending on the analyte?
I know, it seems random.
Yeah, like glucose jumps from 99 down to 5.5, but BUN collapses from 20 to 7.1. There's no universal multiplier.
And there can't be, because it all comes down to the individual molecular weight of the analyte. A mole is just a specific number of molecules, right? Avogadro's number.
Okay.
Because glucose is a relatively large, heavy molecule. It has a molecular weight of roughly 180. It takes fewer moles to make up the same physical mass.
So concentration of 99 milligrams is only 5.5 millimoles.
Exactly. BUN is a much lighter molecule, so its conversion factor is completely different. You're dividing the conventional mass by its specific atomic weight to get the molarity.
So as a test taker, I shouldn't be trying to calculate these on the fly in the testing center.
No. Absolutely do not waste time doing that.
Right. We just need to memorize the anchor points of the new reference ranges. Like, if I know that a glucose of 5.5 is the absolute ceiling of normal in SI units, that anchors my clinical judgment.
Precisely. So let's walk through a scenario. Say you get a board question where a patient presents with a fasting glucose of 5.2 millimoles per liter. Yeah. And the question asks for the clinical interpretation.
Okay, I'll give everyone a second to think about that. Is 5.0 normal? My instinct with the number 5.0 might be to think it's dangerously low if I'm stuck in conventional mode.
Right, because 5 is way below 70.
Exactly. But in SI units, 5.0 is perfectly normal. It falls right in that 3.9 to 5.5 millimoles per liter range, which perfectly correlates to the 70 to 99 conventional.
Spot on. Okay, what if a BUN is reported at 7.1 millimoles per liter? Think about that for a second. Is the patient in renal failure?
Well, let's see. No, because 7.1 is the exact upper limit of normal for SI units. It corresponds perfectly to 20 milligrams per deciliter.
Right. The trap there is seeing a single-digit BUN and thinking it's artificially low, or seeing it in an SI context and totally panicking.
It's all about context. And speaking of context, before those numbers even reach the analyzer, the blood has to actually travel from the patient's arm to the lab.
Oh, the pre-analytical phase.
Yeah, that's where, like 70% of all laboratory errors occur?
Easily 70%. These are the variables that ruin a perfectly good sample before the chemistry tech even takes the cap off the tube.
So let's break those down. They really seem to fall into two camps. You've got physiological shifts, where the patient's body is changing the chemistry naturally, and mechanical errors, where we mess it up during the draw.
Right. For the physiological side, diurnal variation is huge. The body runs on a strict biological clock.
Okay, so morning versus evening.
Exactly. In the morning, or the AM hours, you'll see significant predictable increases in ACTH, cortisol, and iron. Cortisol is literally the body's waking hormone, so it spikes to prepare you for the day.
Makes sense. And in the afternoon?
In the PM, the spikes happen in growth hormone, parathyroid hormone, and TSH. So a doctor tries to track a patient's cortisol, but draws it at 8 a.m. on Monday and 4 p.m. on Tuesday.
The data is clinically useless.
Completely useless.
And posture plays a massive role, too, which I always found fascinating. Like, just the act of a patient standing up shifts fluid out of the intravascular space into the tissues.
Yeah, just gravity and hydrostatic pressure at work.
Right. And that fluid loss artificially concentrates the large molecules left behind in the blood, along with the analytes bound to them. So albumin, cholesterol, and total calcium all physically increase in concentration when a patient has been standing.
Exactly. Then you cross into the mechanical errors. Leaving a tourniquet on for greater than 1 minute is a classic board question.
Because it creates localized venous stasis and hypoxia in the arm, right?
Yes. The starved cells shift to anaerobic metabolism, which spikes lactic acid. The pressure forces fluid out of the vein, which falsely increases total protein.
And as those starved cells begin to leak, potassium starts creeping out into the serum.
Exactly. Then there's IV contamination. Drawing above an active intravenous line introduces whatever's in that bag directly into the sample.
So if they're on a normal saline drip, your sodium and chloride will just be through the roof.
Yep, and everything else will be diluted to near zero. But the granddaddy of all collection errors, the one that will absolutely be on the test, is K2-EDTA cross-contamination.
The dreaded lavender top tube.
The worst. K2-EDTA is an aggressive anticoagulant. It works by chelating calcium. It permanently binds the calcium in the blood, so the coagulation cascade cannot physically function.
Leaving the blood liquid.
Right. So if a phlebotomist draws a lavender tube and then drags even a microscopic drop of that EDTA into a green or red chemistry tube on the next draw, it creates total chaos.
Because it chelates all the analytical calcium in that new tube down to zero.
Exactly. The analyzer looks for calcium and finds nothing. It also severely drops magnesium.
And wait, there's a huge spike too, right?
Yes. Simultaneously, because the EDTA is formulated as a potassium salt, that's the K in K2-EDA, it introduces a massive, lethal-looking potassium load into the serum.
Okay, I was reading about a case where a lab got a sample with critical potassium, let's say over 9.0, but the calcium was basically zero. My first thought was that the patient is actively coding.
Oh, they'd be dead.
Right. But you're saying the tech's first thought shouldn't be the patient, it should be the tube itself.
100%. A potassium of 9.0 with an undetectable calcium is almost biologically incompatible with life. The patient would be in fatal cardiac arrest.
So when you see that specific pattern, high potassium, low calcium, low magnesium, it is almost always K2-EDTA tube contamination.
Always. We also have to know the difference between sample types. A classic trick question is why potassium is physically higher in serum than in plasma.
Oh, right. Because serum is what's left after the blood clots, right?
Exactly. During that clotting process, platelets are activated and physically rupture, releasing their internal contents. And platelets are packed with intracellular potassium.
So serum potassium is normally slightly higher than plasma potassium simply because of the damage done during clotting.
Precisely. Conversely, glucose is generally higher in plasma than in whole blood. The red cells themselves contain very little glucose, so they dilute the overall concentration if they're left in.
And hemolysis, that's when red blood cells are physically ripped open during the draw, maybe from a needle that's too small or shaking the tube too hard.
Yeah, it literally spills the guts of the red blood cell into the serum.
Which spikes potassium, magnesium, phosphorus, lactate dehydrogenase, and AST.
Exactly. The sheer volume of intracellular potassium is so extraordinarily high that the slightest mechanical disruption like hemolysis or aggressive fist pumping by the patient will create a false hyperkalemia.
Okay, let's lock this down with a scenario. A fasting patient is drawn at 8 a.m. for a baseline panel, and then drawn again at 4 p.m. for a comparison. Take a second. Which specific analytes are going to be significantly higher in that afternoon specimen just based on biology?
Based purely on diurnal variation, you'd expect higher levels of growth hormone, parathyroid hormone, and thyroid-stimulating hormone in that PM draw.
So the key takeaway here is that recognizing these pre-analytical spikes saves you from misinterpreting a completely valid analytic method.
Exactly. Don't blame the machine for bad draw.
But eventually, the sample does make it to the machine. Let's open the black box. Analytic methods and automation. We need to break down how these instruments actually, see the chemistry.
It almost always starts with light. Spectrophotometry is the total workhorse of the lab.
Right. And the basic principle is that a chemical reaction in the cuvette produces a colored substance. That substance absorbs specific wavelengths of light.
Exactly. The darker the color, the more light it absorbs, and the higher the concentration of the analyte.
But the boards don't just want the concept. They want the hardware. You must know your lamps.
Oh, absolutely. If the analyzer is reading in the visible spectrum, which is roughly 380 to 750 nanometers, it uses an incandescent tungsten lamp.
Tungsten for visible. Got it.
But if it's reading in the ultraviolet range, like for a lot of enzymatic NADH reactions, it has to switch to a deuterium lamp.
And you must know the math governing it too, right? Absorbance equals 2 minus the log of percent transmittance.
Yes, burn that formula into your brain. But standard spectrophotometry isn't sensitive enough for everything. When we need to measure trace metals like lead, copper, or zinc, we upgrade to atomic absorption spectrophotometry, or AS.
Okay, so how does AS differ from standard spectro?
Well, standard spectrophotometry measures light absorbed by molecules in a liquid. AS measures light absorbed by ground state atoms in a flame.
Wow, okay, in a flame.
Yeah, and the hardware path is strictly tested. You start with a hollow cathode lamp. What's brilliant about this is that the cathode inside the lamp is literally made of the metal you're trying to measure.
Oh, that is cool. So if you are looking for lead, you literally use a lead lamp.
Exactly. It emits the exact, highly specific wavelength that lead atoms will absorb.
So the light goes from the hollow cathode lamp, and then where?
It travels through a chopper, which pulses the light to distinguish it from the constant light of the flame. Then it hits the atomizer, usually a flame, which breaks the chemical bonds in the sample, reducing the metal to ground state atoms.
Right, and then the light passes through that atomic cloud into a monochromator to isolate the specific wavelength, and finally to the detector.
You got it. That's the exact path.
Now let's talk about fluorometry. This is where atoms absorb light at a specific wavelength, get excited, and then as they drop back to their ground state, they emit light at a longer, lower energy wavelength.
Right, fluorescence.
But the defining feature here is the physical layout. Fluorometers place the detector at a 90-degree angle to the light source.
Yes, they have to.
I always picture it like trying to look at the reflection of the sun on a lake. You have to look away from the direct sun so you don't go blind. You just want to see the glow.
That's a perfect analogy.
Yeah.
You are actively avoiding the blinding intensity of the excitation lamp. But what if you didn't need an excitation lamp at all? That brings us to chemiluminescence.
Right, where the chemical reaction itself produces the flash of light.
Yes, usually through the oxidation of compounds like luminol or acridinium esters. Because there is absolutely no background excitation light to filter out, the signal-to-noise ratio is pristine.
Which is why it's the gold standard for modern immunoassays measuring tiny amounts of hormones or tumor markers.
Exactly. It's exponentially more sensitive than standard fluorometry.
And when we aren't measuring light, we're usually separating complex mixtures using chromatography. There's thin layer chromatography, or TLC, which is historically a urine screening test.
Right. You spot the urine on a plate, put it in a solvent, and watch it wick up. You identify the drugs using RF values, the distance the specific compound traveled divided by the total distance the solvent front traveled.
Then you have high-performance liquid chromatography, or HPLC. This takes that concept and puts it under immense pressure, forcing the liquid mobile phase through a tightly packed column.
Yes, and in HPLC, the boards will test you on two specific parameters. You determine the concentration of the analyte by calculating the peak-height ratio.
Which is the height of the analyte peak divided by the height of an internal standard peak, right?
Exactly. But for identification of the substance itself, you rely on retention time, how long it took the compound to exit the column.
And gas chromatography, or GC, operates on a similar principle but separates volatile compounds by turning them into a gas and pushing them through a heated coil in an oven.
Right, again, retention time is the key for definitive identification there, too.
We also have ion-selective electrodes, or ICs, which measure the potential difference across a highly specific membrane, like a valinomycin membrane is used specifically for potassium, right?
Yes, valinomycin for potassium is a huge board favorite. We also use osmometry, which measures the total number of dissolved particles in a solution.
The most common laboratory method for that is freezing point depression. The more particles dissolved in the serum, the lower the freezing point drops.
Exactly. So let's run a troubleshooting scenario.
Yeah.
An older analyzer in your lab uses a hollow cathode lamp specific to the analyte, and it involves an open flame to atomize the sample. Think for a second. What method is this, and what is it primarily used for?
Okay. Hollow cathode lamp and a flame. That is atomic absorption spectrophotometry, or AAS, and it is the definitive method for measuring trace heavy metals.
Spot on. Okay, next case. If you're looking at an HPLC readout, how are you determining the concentration of the drug versus confirming its actual identity? Take a moment.
Let's see. Concentration comes from the peak-height ratio compared to an internal standard. Identification is strictly based on the retention time.
Perfect. So the machines are amazing, but physicians rarely order just one test. They order panels. The boards expect you to know exactly which analytes belong in which test group. Let's map out the chemistry panels.
All right, let's start with the basic metabolic panel, or BMP. This is the core foundation. It includes the electrolytes, sodium, potassium, chloride, and CO2.
Plus the glucose and the renal markers, creatinine and BUN. And finally, calcium. So 8 tests total.
Got it. Now, when you upgrade to the comprehensive metabolic panel, or CMP, you take that entire BMP and you add the liver and protein markers.
Right. Specifically, albumin, total protein, alkaline phosphatase, or ALP-AST, and total bilirubin.
Then we have the targeted organ panels. The hepatic function panel drills down into the liver. It includes albumin, ALT, AST, ALP, both total and direct bilirubin, and total protein.
Which is a really comprehensive look at liver health.
But wait, I'm looking at the hepatic list. Gamma-glutamyl-transferase, or GGT, is a highly sensitive biliary marker. It is famously sensitive to liver damage. Why on earth is it excluded from the standard hepatic panel?
It's a great question, and it comes down to specificity and cost-effective screening. GGT is almost, well, too sensitive.
Too sensitive? How?
It spikes with routine alcohol intake, even just a few drinks over the weekend, or minor biliary stasis. If it were on the standard screening panel, you would have an absolute epidemic of false alarms.
Oh, okay.
So ALP is preferred for the primary panel to detect frank biliary obstruction. GGT is reserved as a highly specific follow-up test.
So if a patient's ALP is elevated, the doctor orders a GGT to clarify. If the GGT is also high, the issue is definitely the liver. If the GGT is normal, the elevated ALP is probably coming from the bone.
Exactly. It differentiates the source.
Okay.
Let's look at the lipid panel. It strictly looks at total cholesterol, HDL, LDL, and triglycerides.
And finally, there's the renal function panel. This is the entire BMP plus albumin and phosphate. Why is phosphate added when evaluating the kidneys?
Because of its reciprocal regulatory relationship with calcium. When the kidney fails, it can no longer excrete phosphate properly, so phosphate levels build up in the blood.
And because of their chemical relationship, that high phosphate drives serum calcium down. Monitoring both is critical for patients in real renal failure.
Exactly. Let's do a panel selection case. A physician orders a BMP, but calls the lab and says they also really need to check albumin and phosphorus. Let's think for a second. Which single standardized panel covers all these requirements?
That would be the renal function panel.
Perfect. And what if a patient is undergoing a cardiovascular risk assessment and the doctor needs to know their circulating triglycerides? Think about what panel is run and what is the strict patient requirement.
Okay, that's definitely the lipid panel. And the absolute requirement is a 12-hour fasting specimen. Triglycerides spike massively after a meal, turning the serum physically milky or lipemic. If they aren't fasting, the triglyceride measurement is completely invalid for assessing baseline cardiovascular risk.
Exactly right. And that strict requirement for fasting takes us directly into the biochemistry of how we process those specific macros. Carbohydrates, lipids, and proteins. This is where structural biology hits clinical diagnostics.
Starting with fasting glucose. The normal physiological reference range is 70 to 99 milligrams per deciliter. To measure it, laboratories primarily use 2 enzymatic methods, the hexokinase method or the glucose oxidase method.
Right.
Hexokinase is considered the gold standard reference method, right? Why is it better than glucose oxidase?
It's all about interferences. In the hexokinase method, glucose is phosphorylated by ATP, and then a second enzyme, G6PD, oxidizes it. This produces NADH, which we measure spectrophotometrically. It's highly accurate.
Okay, and what about glucose oxidase?
Glucose oxidase relies on the production of hydrogen peroxide, which then reacts with a dye. That secondary peroxidase reaction is easily inhibited by high levels of uric acid, bilirubin, or especially ascorbic acid, vitamin C.
So taking vitamin C could lead to falsely low glucose results on that assay.
Exactly. It interferes with the color change.
We also have to remember that glucose is alive, or at least the cells in the tube are. If you leave a standard red top tube on the counter, the red and white blood cells continue to consume the glucose for energy via glycolysis.
Yeah, the glucose level drops by about 5 to 7% every hour.
To stop this, if testing is going to be delayed, you must draw the blood in a gray top tube containing sodium fluoride. The fluoride ion literally poisons the glycolytic enzymes, freezing the glucose level in place.
Right. Moving to the coronary artery disease, or CAD, lipids, you need to know the desirable physiological targets for the boards.
Total cholesterol should be under 200 milligrams per deciliter. HDL, the good cholesterol, should be over 60. LDL, the bad cholesterol, should be under 100. And triglycerides should be under 150.
And the analytical methods for HDL are really clever nowadays. We use direct homogeneous assays. You don't have to physically centrifuge or chemically precipitate the other lipids anymore.
Right. The first region acts like a chemical shield. It binds and blocks all the non-HDL lipoproteins like LDL and VLDL. Then the second region comes in and reacts exclusively with the exposed HDL fraction. It's an elegant solution.
It really is. Then we have the massive structural proteins. Total protein runs 64 to 83 grams per liter, or 6.4 to 8.3 grams per deciliter. The classic measurement is the Biuret method.
That uses an alkaline copper reagent that reacts specifically with peptide bonds, right? The more peptide bonds present, meaning the longer and more abundant the proteins, the deeper the purple color complex it forms.
Exactly. Albumin makes up the largest single fraction of those plasma proteins, ranging from 3.5 to 5 grams per deciliter. It's synthesized exclusively by the liver.
I always describe albumin as the sponge keeping fluid inside the blood vessels. It maintains the oncotic osmotic pressure. When albumin drops significantly, the water isn't held in the vessels anymore. It leaks out into the interstitial tissue.
Right. Hello, peripheral edema and ascites.
To measure albumin specifically, we use dye binding methods. The proteins bind to dyes like bromocresol green, BCG, or bromocresol purple, BCP, causing a shift in the absorption maximum of the dye.
We also track albumin in the urine, but at much lower levels. Microalbumin is defined as 50 to 200 milligrams of albumin excreted per 24 hours.
Why do we care about such a tiny amount?
Because it is highly predictive of diabetic nephropathy. A standard urine dipstick won't detect protein until there's a massive amount of macroscopic damage to the glomerulus. Microalbuminuria detects the absolute earliest stages of kidney damage in diabetics. It allows physicians to intervene with aggressive glucose and blood pressure control before it progresses to irreversible end-stage renal disease.
Let's run a clinical correlation on that. A patient arrives at the clinic with severe peripheral edema, swelling in their legs and abdomen. Their liver enzymes are abnormal, and their serum albumin is 2.5 grams per deciliter. Give it some thought. What dye-binding laboratory methods specifically measure this depleted fraction?
That would be bromocresol green, or BCG, and bromocresol purple, or BCP.
Next case. A patient with a 10-year history of type 2 diabetes has a routine urine dipstick that is completely negative for protein. However, a specialized 24-hour urine collection reveals 150 milligrams of albumin. Take a second. What is this predictive of?
Microalbuminuria. It is the earliest biological predictor of diabetic nephropathy.
Catching that early is life-saving, which makes strict hormonal glucose control absolutely critical. Let's shift into glucose regulation and diabetes mellitus. This is basically the body's energy management system.
And the primary physiological regulator is insulin. It is synthesized by the beta cells of the islets of Langerhans in the pancreas.
Its entire biological purpose is to decrease plasma glucose. It does this by binding to cellular receptors, acting as a key to literally open channels that force glucose out of the blood and into the cells.
Right. It also increases glycogenesis, which is the storage of excess glucose as glycogen in the liver.
But the body is fundamentally terrified of starving. So while it only has one hormone to lower blood sugar, it has an entire army of antagonists to raise it. Think of glucagon, cortisol, epinephrine, and growth hormone as the four horsemen of hyperglycemia.
Evolutionarily, acute hypoglycemia is an immediate, lethal threat to the brain, which relies entirely on a continuous supply of glucose. If your blood sugar drops to 0, you die in minutes.
Wow, yeah.
Hyperglycemia, conversely, is a slow-burning problem that kills you over decades. So the body prioritizes raising sugar. Glucagon, produced by the alpha cells in the pancreas, stimulates the liver to break down its glycogen stores.
Cortisol, from the adrenal cortex, increases gluconeogenesis, literally making new glucose from amino acids. Epinephrine promotes rapid glucose release under acute fight-or-flight stress. Even thyroxine increases the baseline glucose absorption from your gut.
Which brings us to the pathology when this system breaks. Diabetes mellitus. Type 1 is an autoimmune condition. The body's own immune system attacks and destroys the pancreatic beta cells, causing an absolute total deficiency of insulin.
It has a strong genetic predisposition linked to the HLA-DR3 and 4 antigens, right? And because they have zero insulin, these patients are highly prone to life-threatening diabetic ketoacidosis.
Exactly. Type 2 is entirely different. The pancreas is making insulin, but the peripheral tissues have developed insulin resistance. The key no longer turns the lock. This is heavily associated with obesity and metabolic syndrome.
Then there is gestational diabetes mellitus, where human placental lactogen, a hormone produced by the placenta during pregnancy, directly inhibits the action of maternal insulin, causing hyperglycemia.
You must know the diagnostic cutoffs for diabetes cold. No hesitation.
Okay, let's list them. A fasting plasma glucose greater than or equal to 126 milligrams per deciliter, a random glucose or a 2-hour oral glucose tolerance test greater than or equal to 200 milligrams per deciliter, or hemoglobin A1C greater than or equal to 6.5%.
And the absolute critical caveat for the boards. Any of these results requires testing on 2 separate occasions for a definitive diagnosis unless the patient is actively in crisis.
We often see type 2 clustered with metabolic syndrome. This is a recognized group of physical risk factors acting synergistically. If a patient has decreased HDL, increased LDL, elevated triglycerides, high blood pressure, and a high fasting blood glucose, they meet the criteria.
And it heavily promotes atherosclerotic cardiovascular disease. But when diabetes goes fully uncontrolled, particularly type 1, the laboratory profile shifts radically into diabetic ketoacidosis.
Without insulin, the cells are starving despite swimming in glucose, so blood glucose skyrockets. It spills over the renal threshold, pulling water with it, causing massive urine output and severe dehydration.
Serum osmolality shoots up. Because the cells can't burn carbs, they burn fat, creating ketone bodies. These ketones heavily acidify the blood, plummeting the pH and bicarbonate and significantly widening the anion gap.
So if I'm looking at a chart in the clinic and a patient had a fasting plasma glucose of 130 milligrams per deciliter drawn yesterday, and a repeat draw today shows 132, think about it. That's it. They crossed the threshold.
Exactly. A fasting plasma glucose of greater than or equal to 126 milligrams per deciliter on 2 separate occasions is the definitive diagnostic criteria for diabetes mellitus.
And what if an obese patient presents with decreased HDL, increased LDL, elevated triglycerides, hypertension, and a fasting glucose of 115? They aren't fully diabetic yet, but what is the overarching diagnosis?
That is metabolic syndrome. It's a constellation of risk factors that dramatically increases the risk of cardiovascular disease.
We've talked about acquired metabolic issues, but what happens when the processing error isn't acquired but genetic from birth? Let's look at aminoacidopathies. These are the inherited inborn errors of metabolism where the body lacks the specific enzyme needed to break down certain amino acids,
leading to toxic systemic buildups. Phenylketonuria, or PKU, is the classic example. It's a severe deficiency in the enzyme phenylalanine hydroxylase, which normally converts phenylene to tyrosine.
Without it, phenylalanine and its metabolite, phenylpyruvic acid, build up massively in the blood and urine. If untreated, it rapidly causes severe, irreversible mental retardation. Historically, it was noted for causing a characteristic mousy or musty odor in the infant's urine.
Tyrosinemia involves a block in tyrosine catabolism, causing massive liver and kidney damage, and the urine has a distinct cabbage odor.
Cabbage odor, got it.
Then there is alkaptonuria. This involves a deficiency that causes a buildup of homogentic acid. The clinical hallmark is visually striking. The infant's diapers stain black upon standing as the acid oxidizes in the air.
Wow. And later in life, this acid deposits in cartilage, darkening connective tissues, a condition called ochronosis, and causing severe debilitating joint pain.
Maple syrup urine disease, or MSUD, is a deficiency in the decarboxylation of branched-chain amino acids, specifically leucine, isoleucine, and valine. The urine, breath, and skin literally smell like heavy burnt sugar or maple syrup.
And it leads to rapid failure to thrive, severe acidosis, seizures, and death if those specific amino acids are not immediately restricted from the diet.
Exactly. Homocystinuria involves a defect in methionine metabolism. It is characterized clinically by osteoporosis, mental retardation, thromboembolic events, and uniquely dislocated lenses in the eyes.
And cystinuria is a transport defect in the kidneys. Cysteine isn't reabsorbed, so it precipitates out, leading to recurring, highly painful kidney stones. It will test positive with the cyanide nitroprusside test, yielding a distinct red-purple color.
Historically, laboratories relied on the Guthrie bacterial inhibition assay, literally growing bacteria on a plate, to see if the blood contained enough amino acid to overcome an inhibitor. Or worse, they waited for clinical symptoms and physical odors.
Yeah, these are the historical scratch-and-sniff diseases of clinical chemistry. But we don't rely on those historical markers anymore, right? We don't wait for a baby's diaper to smell like maple syrup.
No, we absolutely don't. Today, all newborn screening is performed using tandem mass spectrometry, or MSMS. It is infinitely more sensitive.
It provides immediate, definitive molecular identification of the specific amino acid derangement from a single heel prick long before any clinical symptoms or odors ever have a chance to develop.
Exactly. It allows for immediate dietary intervention.
Let's test the classical presentations, because the boards still love the history. A newborn is in the NICU exhibiting failure to thrive and severe metabolic acidosis, and the nurses note the urine smells strongly of burnt sugar. Take a second. What is the suspected diagnosis?
That is maple syrup urine disease, or MSUD.
Second scenario. A panicked parent brings their infant to the pediatrician because the child's diapers are staining black after sitting in the trash. Take a moment. What specific acid is accumulating and oxidizing?
Homogentisic acid, which is the defining characteristic of alkaptonuria.
It's amazing how a single missing enzyme can wreak such systemic havoc. But when we want to look at the big picture of structural proteins, we don't just run mass spec, we force them to race. Let's move to protein electrophoresis.
The analytical principle of electrophoresis is the migration of charged particles in an electrical field. Separation is based entirely on the size, shape, and net charge of the proteins.
We use a support medium, right? Typically cellulose acetate or agarose gel. And crucially, we use a barbital buffer set at a strict alkaline pH of 8.6. Why pH 8.6?
Because the isoelectric point of most serum proteins is lower than 8.6.
Yeah.
By placing them in a buffer that is more alkaline than their isoelectric point, the proteins take on a negative charge. They become anions.
Therefore, they will migrate toward the positively charged anode. I always remember it as A attracts negative charges, the anode attracts anions.
That's a great way to remember it. As the current runs, the proteins separate into distinct bands based on speed. The visual migration order from fastest to slowest is albumin way out front. It's small and highly charged.
Then the alpha-1 globulins, the alpha-2 globulins, the beta globulins, and finally trailing in the back, the slow, bulky gamma globulins, which are your antibodies. We visualize these bands using specific stains like Ponceau S, Amido Blue, or Kumasi Brilliant Blue.
But there is a physical phenomenon you must understand called electroendosmosis. The agarose gel itself has fixed negative charges. When the current is applied, a cloud of positive buffer ions flows backward toward the negative cathode.
This fluid flow physically sweeps the weakly charged gamma globulins backward, which is why they often appear behind the point of application on the gel.
Exactly. The actual serum protein electrophoresis, or SPEP, patterns are incredibly high yield. They form visual landscapes of disease. In acute inflammation, the body rapidly ramps up acute phase reactants, leading to a distinct immediate spike in the alpha-1 and alpha-2 fractions.
In chronic infection, you see that same increase in alpha-1 and alpha-2, but you also see a broad polyclonal increase in the entire gamma region as diverse antibodies are continuously produced over time.
The liver patterns are distinct. What happens visually on the gel when the liver fails in cirrhosis? You see a specific phenomenon called beta-gamma bridging.
Right. The failing liver can't properly clear IgA, and it produces a fast-moving class of gamma globulins. These migrate right into the space between the beta and gamma zones, causing the two normally distinct peaks to fuse together into a single broad, muddy bridge.
Contrast that with a monoclonal gammopathy like multiple myeloma. This isn't a broad immune response. This is a single mutated clone of plasma cells going rogue. They produce massive, terrifying amounts of one specific identical immunoglobulin.
This creates a sharp, towering spike in the gamma region known as an M spike. And because the bone marrow is choked with these mutant cells, all other normal protein fractions actually decrease.
In nephrotic syndrome, the damaged kidney basement membrane acts like a torn sieve. It leaks small proteins. Albumin is lost massively into the urine, causing the serum albumin peak to drop severely.
But the liver panics and overcompensates by producing massive alpha-2 macroglobulins. These are too physically large to fit through the damaged kidney, so they are retained in the blood, causing a sharp, towering spike in the alpha-2 region.
Finally, in alpha-1 antitrypsin deficiency, a genetic lack of the protein causes the alpha-1 peak to simply disappear entirely, leaving a flat line where a peak should be.
Let's analyze a gel. A patient's SPEP shows a polyclonal increase with distinct beta-gamma bridging. The valley between the beta and gamma peaks is completely filled in. Think about it. What is the condition?
That is the hallmark of cirrhosis. The liver's failure alters immunoglobulin clearance, physically merging the beta and gamma zones.
Next case. A SPEP pattern reveals severely decreased albumin, but a massive sharp increase in the alpha-2 globulin fraction. Take a second. What is the diagnosis?
Nephrotic syndrome. The damaged kidneys leak the small albumin, while the massive alpha-2 macroglobulins are retained and overproduced.
And the classic board trap here is if a tech accidentally runs plasma instead of serum. Plasma still contains fibrinogen, which creates a sharp band between the beta and gamma regions that completely mimics a true monoclonal M spike. Always run serum.
Yeah.
Moving from intact proteins to their breakdown products, let's look at the non-protein nitrogen compounds, or NPNs. This is the biochemical waste management system.
First is blood urea nitrogen, or BUN. When the body breaks down amino acids, it generates cellular ammonia, which is highly neurotoxic. The liver acts as a detoxifier, synthesizing that ammonia into water-soluble urea via the urea cycle.
That urea is dumped into the blood and excreted by the kidneys. We measure it using the enzymatic urese method. You must remember that you cannot use sodium fluoride, EDTA, or citrate tubes for a BUN, as those additives directly inhibit the urese enzyme, yielding falsely low results.
Creatinine is different. It is the constant daily waste product of muscle metabolism, formed from the spontaneous dehydration of creatine. Because it is produced at a steady rate based on muscle mass and filtered entirely by the kidneys without significant reabsorption, it is the perfect marker for kidney function.
The classic measurement method is the Jaffa reaction, utilizing an alkaline picrate solution to form a red-orange complex. A critical diagnostic tool combining these two is the BUN to creatinine ratio, which normally sits between 10 to 20.
Then we have uric acid, the end product of purine or nucleic acid metabolism. It is highly elevated in gout, precipitating into painful crystals in the joints.
It's also elevated in renal failure and, critically, in rapid cell turnover states like leukemia or lymphoma, especially during chemotherapy when massive amounts of cellular DNA are being destroyed. We measure it using the specific uricase method.
And then there's ammonia. In the lab, ammonia is a VIP analyte. It demands immediate VIP transport.
Why is it so unstable?
Because ammonia is incredibly volatile and constantly being generated in vitro. If you draw a tube of blood and just leave it on the counter, the cellular enzymes inside that tube continue to deaminate amino acids, actively generating new ammonia.
Even the normal physiological clotting process in a standard red top tube will generate false ammonia. Therefore, it must be collected strictly in an EDTA or heparin tube, placed instantly on an ice slurry to freeze that enzymatic activity, and analyzed immediately.
Let's run a handling scenario. A phlebotomist draws a specimen for ammonia in a plain red top tube and leaves it at room temperature on the rack for an hour before bringing it to chemistry. I'll let you think. Is this acceptable?
Absolutely not. The ammonia must be collected in EDTA or heparin, placed on an ice slurry, and analyzed immediately. That room temperature red top will have a falsely critical ammonia level from in vitro generation during clotting and cell metabolism.
Let's interpret a ratio. A patient arrives in the ER severely dehydrated. Their BUN is 40 milligrams per deciliter, and their creatinine is 1.0 milligrams per deciliter. Think about it for a second. What does this ratio indicate?
The BUN to creatinine ratio is 40. This severely elevated ratio, paired with a perfectly normal creatinine, indicates a prerenal condition. The kidney structure itself is functionally intact, which we know because it is clearing creatinine properly. But because the patient is dehydrated, blood flow to the kidney is reduced.
Exactly. The sluggish flow allows the urea to be passively reabsorbed back into the blood, driving up the BUN.
Precisely. Prerenal means the kidney structure is fine, but the flow to it isn't. While the kidneys clear waste, they also meticulously balance the body's battery fluid. Let's look at electrolytes in iron, the charged particles driving action potentials and the heavy metals driving oxygen.
Sodium is the major extracellular cation. It is the dominant force determining plasma osmolality and massive water distribution shifts. Wherever sodium goes, water follows.
Potassium is the major intracellular occasion. It dictates the resting membrane potential of muscle cells, specifically cardiac muscle. Even slight variations in serum potassium are highly arrhythmogenic.
Chloride is the major extracellular anion, usually passively following sodium to maintain electrical neutrality. And phosphorus is the major intracellular anion, maintaining that strictly reciprocal regulatory relationship to calcium we discussed earlier.
We also measure lactate, or lactic acid. This is the metabolic footprint of tissue hypoxia. When cells don't have oxygen, they shift from aerobic to anaerobic metabolism, producing lactate.
It must be collected without a tourniquet to avoid artificial stasis and drawn in a specialized fluoride tube to permanently inhibit ongoing glycolysis in the red blood cells.
For iron, we don't just look at a single number. We require an entire dynamic panel to understand the pathology. Serum iron is the raw circulating metal. Total iron binding capacity, or TIBC, represents the total amount of transferrin available to carry that iron.
Percent saturation is the calculated ratio of iron divided by TIBC. Transferrin is the specific transport protein itself, and ferritin is the primary intracellular storage form of iron. It reflects the body's deep tissue reserves.
I always think of iron as passengers, transferrin as the bus, and ferritin as the bus depot. In iron deficiency anemia, the depot is completely empty, so ferritin drops. The body desperately tries to capture more iron, so it builds more buses, meaning TIBC and transferrin massively increase.
But because there are no passengers, the serum iron is severely decreased.
Conversely, in hemochromatosis, which is severe genetic iron overload, the buses are completely full and the depot is overflowing. Serum iron and ferritin are markedly increased. The body realizes it has a toxic amount of iron, so it stops building redundant buses, causing TIBC to decrease.
I want to circle back to potassium and the mechanics of the blood draw. We mentioned earlier that squeezing a capillary site or having a patient pump their fist artificially spikes potassium. What is the physical mechanism there?
The physiological concentration of potassium inside a human cell is roughly 40 times higher than in the surrounding serum. If you aggressively squeeze a finger stick, you are forcing interstitial tissue fluid and ruptured cellular contents directly into the capillary blood.
If a patient pumps their fist, it causes physical shear stress and local metabolic acidosis in the muscle, forcing potassium to leak out of the muscle cells and into the blood. It results in a massive false elevation that does not reflect the patient's systemic state.
Let's test the iron profiles. A patient's lab results show severely decreased serum iron, a highly increased TIBC, and decreased ferritin. Take a moment. What is the underlying diagnosis?
Iron deficiency anemia. The body is starved for iron, so it empties its ferritin stores and ramps up its binding capacity in a desperate attempt to capture any available iron.
Second scenario. A phlebotomist has a difficult draw and asks the patient to pump their fist vigorously. The resulting sample is slightly hemolyzed. Think about it. Which major intracellular rotation will be falsely, perhaps critically, elevated?
Potassium. Pumping the fist and hemolysis both violently release massive amounts of intracellular potassium into the surrounding serum.
And the danger there is the doctor running the K anyway, assuming it's real, and medically treating the patient with insulin and glucose for a hyperkalemia they don't actually have, driving their real potassium fatally low.
Yeah, that's a nightmare scenario.
When cells die, they don't just spill electrolytes, they spill their highly specific catalytic machinery. Let's look at enzymes and cardiac markers.
First, a critical fundamental note on enzyme kinetics. In the lab, we don't usually measure the physical mass of an enzyme. We measure its catalytic activity. To do this accurately, the reaction must be in first-order kinetics.
This means the enzyme concentration is the sole limiting factor. The substrate we provide in the reagent must be present in massive, saturating, zero-order excess. As long as the substrate is infinite, the speed of the reaction is strictly proportional to the amount of enzyme present in the patient's serum.
Exactly. Let's map these enzymes to their specific organs. Acid phosphatase, or ACP, maps primarily to the prostate. Alkaline phosphatase, ALP, maps heavily to the liver and the rapidly turning over bone.
AST and ALT map strongly to the liver, though AST is also found in skeletal and cardiac muscle tissue. Gamma-glutamyl transferase, GGT, maps to the biliary tract and is highly sensitive to alcohol induction.
Creatine kinase, CK, and lactate dehydrogenase, LD, map to skeletal muscle and the heart, serving as classic historical markers of an acute myocardial infarction, or AMI. Amylase and lipase map almost exclusively to the pancreas. Glucose 6-phosphate dehydrogenase, G6PD, is found inside red blood cells, protecting them from oxidative stress.
The disease profiles are heavily tested. An AMI traditionally showed elevations in CKMB and LD flips, though today we rely almost entirely on the much more specific troponin complex, which stays elevated for over a week.
A hepatic or primary hepatocellular issue like acute viral hepatitis shows massive skyrocketing spikes in AST and ALT because the liver cells are actively dying. A biliary obstruction like a lodged gallstone shows massive spikes in ALP and GGT, while AST and ALT remain relatively mild because the liver cells themselves aren't necrotic yet, they are just backed up.
For acute pancreatitis, both amylase and lipase will spike rapidly. However, lipase is the true sniper of pancreatic markers. It is highly specific to the pancreas and stays on target, remaining elevated in the serum for up to 2 weeks.
Amylase is less specific, it's also found in saliva, and it clears rapidly through the kidneys in just a few days.
Beyond enzymes, we monitor specific cardiac proteins. B-type natriuretic peptide, or BNP, is released directly from the heart muscle of the left ventricle when it physically stretches due to fluid overload and congestive heart failure. It acts on the kidneys to increase sodium and fluid excretion.
We also monitor high-sensitivity CRP, hsCRP, not to diagnose a heart attack, but as a baseline non-specific inflammatory marker to predict a patient's future risk for coronary artery disease.
Let's run a diagnostic map. A patient presents to the clinic with visible jaundice. Their AST and ALT are only mildly elevated, but their ALP and GGT are markedly, severely increased. Take a second.
Yeah.
What is the anatomical location of the disease?
It's a biliary tract obstruction. The ALP and GGT map perfectly to the biliary tree. The mild transaminases rule out primary hepatocellular damage.
Next case. A patient arrives with severe radiating abdominal pain. The lab runs a panel showing high amylase and high lipase, confirming acute pancreatitis. Think about it. Which of these two enzymes will remain elevated longer to allow the physician to monitor the resolution of the attack?
Lipase. It hydrolyzes dietary triglycerides and persists in the serum much longer than the rapidly cleared amylase.
So we see how a blocked bile duct backs up the liver's plumbing and spikes ALP. But what is actually in that backed up fluid? That leads us perfectly into section 12, bilirubin and jaundice. The breakdown of blood.
The metabolic pathway of bilirubin is a strict chronological assembly line. Red blood cells reach the end of their 120-day lifespan and are broken down by macrophages in the reticuloendothelial system. The heme ring of the hemoglobin is cracked open, creating unconjugated bilirubin.
This form is completely insoluble in water. It is lipid-soluble. To travel safely through the watery blood without precipitating out, it must physically bind to a carrier protein, which is albumin.
The albumin bus carries it to the liver factory. Here, the enzyme UDP-glucuronal transferase attaches glucuronic acid molecules to it. This transforms it into conjugated bilirubin.
This FON is highly water-soluble. It is excreted into the bile ducts, flows into the intestines, and is converted by normal gut bacteria into urobilinogen, which is eventually oxidized into stercobilin, giving feces its characteristic brown color.
The clinical differentials of jaundice rely entirely on tracking where this pathway broke down. In prehepatic jaundice, like a massive hemolytic anemia or a transfusion reaction, the liver is fine, but it is overwhelmed by an influx of raw material from dying red cells. You see a huge increase in unconjugated bilirubin in the blood.
In hepatic jaundice, like severe viral hepatitis or cirrhosis, the factory floor itself is broken. You see increases in both unconjugated and conjugated bilirubin because the liver can process some of it, but the damaged necrotic cells leak everything back out into the blood.
In post-hepatic jaundice, the plumbing is physically blocked, usually by a gallstone or a pancreatic tumor. The liver is healthy and successfully conjugating the bilirubin, but it physically cannot excrete it into the intestine.
It backs up under immense pressure and spills entirely into the blood, resulting in massively increased conjugated bilirubin. Because this form is water-soluble, it spills over the renal threshold into the urine, making the urine a dark amber.
Simultaneously, because no bilirubin is reaching the gut, the stool becomes chalky and pale due to a complete lack of intestinal urobilinogen.
We measure this in the lab using the Jondrasik-Groff method with a diazo reagent. Total bilirubin requires an accelerator, chemical like caffeine benzoate, to force the stubbornly insoluble unconjugated fraction into solution so it can react.
Direct bilirubin, which is the already water-soluble conjugated form, reacts directly with the diazo reagent without any accelerator required. Indirect, unconjugated bilirubin is then calculated by subtracting direct from total.
Unconjugated is the raw material. Conjugated is the water-soluble packaged product. Let's test the extremes. A neonate has a total bilirubin of 22 milligrams per deciliter, heavily unconjugated. Take a second. What catastrophic physiological complication is associated with this?
Kernicterus. High levels of fat-soluble unconjugated bilirubin easily cross the immature neonatal blood-brain barrier and deposit directly into the lipid-rich basal ganglia, causing severe, irreversible brain damage.
Second scenario. A patient's lab results show severely elevated direct bilirubin, but completely normal indirect bilirubin. I'll let you think. Where's the anatomical issue?
Posthepatic. This indicates obstructive jaundice. The liver is successfully conjugating the bilirubin, but a physical blockage prevents excretion, forcing the direct bilirubin back into circulation.
And because it's direct and water-soluble, that patient's urine will be positive for bilirubin. But none of these organ systems operate independently. They are managed by chemical messengers dictating energy use, growth, and reproduction. Which brings us to endocrinology. We are sticking strictly to the markers outlined in our source text.
We extensively covered the pancreatic hormones. Insulin from the beta cells forcing glucose into cells, and glucagon from the alpha cells stimulating glycogenolysis to rapidly increase glucose. But we also have to track the reproductive hormones, specifically human chorionic gonadotropin, or HCG.
In a routine obstetric setting, HCG is used to confirm pregnancy and assess placental function. But in an oncology setting, it is a vital, highly specific diagnostic marker. It is exponentially elevated in gestational trophoblastic diseases, like a hydatidiform mole or choriocarcinoma.
And crucially, it is a primary, indispensable marker for diagnosing and tracking HCG-producing testicular tumors in males.
The stress and metabolic hormones play a crucial regulatory role as well. Cortisol and ACTH, produced in the adrenal cortex and the anterior pituitary respectively, act in a tight negative feedback loop. They are drastically increased by acute stress and exhibit that strong diurnal variation, peaking heavily in the early morning.
And thyroxine, or T4, from the thyroid gland, while mostly governing overall basal metabolic rate and cellular oxygen consumption, also acts specifically to increase glucose absorption from the gastrointestinal tract.
Let's run an oncology correlation. A male patient presents with a solid testicular mass, and the physician orders a serum HCG, which comes back markedly elevated. Think about it. What does this indicate?
An HCG-producing testicular tumor. While usually thought of as a pregnancy marker, the beta subunit of HCG is highly diagnostic for specific male germ cell neoplasms.
Next, a patient presents with severe recurring fasting hypoglycemia. Exhaustive lab tests show highly elevated endogenous insulin and C-peptide, but the patient has absolutely no history of diabetes or access to insulin medications. Take a second. What is the suspected cellular cause?
An insulinoma. This is an autonomous insulin-producing tumor of the pancreatic beta cells that continuously secretes insulin, regardless of the patient's blood sugar level.
The board trap there is assuming hormones only come from normal glands rather than rogue tumors. What happens when we introduce exogenous chemicals to the system? Let's dive into therapeutic drug monitoring, or TDM, and toxicology. This is the pharmacology wing of the chemistry lab.
In TDM, we are operating between two strict, highly narrow physiological boundaries. First is the minimum effective concentration, or MEC. This is the lowest circulating blood level required to achieve the desired clinical effect.
Second is the minimum toxic concentration, or MTC, which is the level where severe, adverse, poisonous responses begin. The therapeutic index is the calculated ratio of the MTC to the MEC.
I always think of the therapeutic index like parallel parking a semi-truck on a cliff. If you park too far to the left, below the MEC, the drug doesn't work, allowing the systemic infection or the seizure to win. If you park too far to the right above the MTC, you go over the cliff, and the drug becomes toxic, causing massive organ failure.
You need to know the specific drug classes. Analgesics include salicylates like aspirin and acetaminophen. Antiepileptics cover phenytoin, phenobarbital, and carbamazepine.
Antibiotics requiring strict TDM include the aminoglycosides like gentamicin and amikacin and vancomycin due to their profound nephrotoxicity and ototoxicity if the trough levels creep too high. Cardioactives include digoxin. Immunosuppressants like cyclosporine and tacrolimus are absolutely critical to monitor post-transplant to prevent organ rejection.
Moving to toxicology, the analytical testing methods must be legally and biochemically specific. Ethanol is definitively measured via gas chromatography, GC, to physically separate it from other toxic alcohols like methanol or isopropanol, though rapid enzymatic methods exist for ER screening.
Carbon monoxide poisoning is measured using differential spectrophotometry on a co-oximeter, identifying the unique absorbance signature of carboxyhemoglobin versus normal oxyhemoglobin. Heavy metals like arsenic and lead require that atomic absorption spectrophotometry we discussed earlier.
And then there is the urine drug screen, or UDS. This is an adversarial game of cat and mouse between the patient and the lab. Patients attempt to defeat the screen in three primary ways. First is adulterated urine. This is the physical addition of a foreign substance or a non-physiological extreme intended to destroy the assay antibodies.
The lab flags this if the pH is incredibly low, like less than 3, or high, greater than 11, or if there are massive nitrites over 500 milligrams per deciliter, or the chemical presence of bleach, iodine, or glutaraldehyde.
Second is substituted urine. This is when the patient literally brings in synthetic urine or apple juice hidden in a warming pouch. The lab flags this when the values are completely biologically inconsistent with human physiology.
Specifically, a creatinine less than 2 milligrams per deciliter combined with a specific gravity less than or equal to 1.0010 or massively high over 1.0200, it doesn't look like human waste because it isn't.
Third is diluted urine. The patient drinks gallons of water before the test to flush their system and drop the drug concentration below the analytical cutoff. This is defined as a creatinine between 2 and 20, and a specific gravity between 1.0010 and 1.0030. It's technically human urine, but it's fundamentally compromised by extreme hydration.
Let's test the validity parameters. A pre-employment urine drug screen shows a creatinine of 1.0 milligrams per deciliter and a specific gravity of 1.0005. I'll let you think. How is the lab required to classify this sample?
It is classified as substituted urine. These values are not consistent with normal human physiology and mathematically indicate the patient swapped the sample with water or a synthetic liquid.
Second scenario. A patient is pulled from a house fire and comes into the ER with cherry red skin. The tech runs a differential spectrophotometry co-oximeter. Take a moment. What specific toxin is being measured?
Carbon monoxide. The co-oximeter measures carboxyhemoglobin at specific isobestic points, differentiating it from functional hemoglobin.
So we monitor exogenous chemicals closely. But what about the chemicals produced by rogue cells within the body? Let's look at tumor markers. These are the biochemical footprints of malignancy. Based strictly on our flashcard source today, we are focusing on two historical but heavily tested markers.
Acid phosphatase, or ACP. The primary tissue source for ACP is the prostate gland. Historically, before the widespread advent and extreme sensitivity of prostate-specific antigen, or PSA, ACP was the primary enzyme tracked by laboratories to diagnose and aggressively monitor the metastasis of prostate cancer.
And we revisit human chorionic gonadotropin, HCG. As a tumor marker, an exponential elevation is the diagnostic hallmark of gestational trophoblastic disease, specifically a hydatid-form mole, as well as being heavily utilized in diagnosing and tracking the recurrence of testicular tumors.
The critical overarching concept you must grasp is that these specific markers, and most tumor markers in general, are rarely used for primary screening of the general asymptomatic public. They lack the absolute specificity and sensitivity required. Non-cancerous inflammatory conditions can cause false positives.
Instead, they are highly valuable for diagnosing specific clinical presentations and, more importantly, tracking the efficacy of surgical treatment or monitoring for insidious disease recurrence.
If tumor markers aren't great for screening the healthy public, what are they actually good for? Monitoring the battlefield after the surgical strike. If a tumor is removed, the marker should drop to 0. If it starts climbing 6 months later, the cancer is back. Let's run a case. A pregnant patient's HCG levels are exponentially higher than expected for her gestational age, and an ultrasound shows a snowstorm pattern. Take a second. What abnormal pathology could the HCG represent?
Gestational trophoblastic disease, such as a hydatidiform mole.
Next, historically, before the discovery of PSA, which specific enzyme was utilized to monitor prostate cancer metastasis? Give it some thought.
Acid phosphatase, or ACP.
And the board trap is forgetting ACP's distinct prostate connection and mixing it up with ALP, which maps to bone. Let's look at the most dynamic volatile sample in the entire laboratory. Acid base and arterial blood gases, the ABG. This is real-time metabolic and respiratory monitoring.
You have to know the specific electrodes utilized in the blood gas analyzer. The PCO2 electrode, known as the Severing-House electrode. It's essentially a modified pH electrode covered with a specific CO2 permeable Teflon or silicone membrane.
The CO2 from the blood crosses the membrane, alters the contained bicarbonate buffer, and the resulting pH change is measured potentiometrically. The PO2 electrode is the classic Clark electrode. It uses a platinum cathode and a silver chloride anode covered by a semi-permeable membrane. Oxygen diffuses across, is actively reduced at the platinum cathode, and the amount of current flow is measured amperemetrically.
The pre-analytical errors in an ABG are notoriously tricky because they overlap and perfectly mimic real physiological disease states, I always tell students. An ABG syringe left on the counter is a living, breathing thing. The white blood cells and red blood cells are still actively consuming oxygen and producing carbon dioxide.
Exactly. If a specimen sits at room temperature for greater than 30 minutes, cellular respiration continues unchecked. The PO2 will steadily decrease as the cells consume it. The PCO2 will steadily increase as the cells produce waste. And because CO2 acts as an acid in the blood, the pH will actively decrease. It looks exactly like respiratory acidosis.
Now contrast that with an air bubble. If a specimen is exposed to room air, or if the patient was hyperventilating wildly during the painful arterial puncture, the profile shifts entirely. Room air has a much higher oxygen concentration and a near zero CO2 concentration compared to venous or arterial blood.
So the PO2 will falsely increase as oxygen diffuses into the sample from the bubble. The PCO2 will falsely decrease as it escapes into the air bubble gradient. And because you are losing acidic CO2, the pH will falsely increase, simulating a respiratory alkalosis.
Let's test the handling errors. An arterial blood gas sample sits at room temperature for 45 minutes before the tech finally runs it. Think about it. How will the PO2 and PCO2 artificially shift?
PO2 will physically decrease due to ongoing cellular respiration, and PCO2 will heavily increase, which directly drives the pH down.
Next, an ABG printout shows a decreased PCO2, an increased pH, and a highly increased PO2. I'll let you think.
Yeah.
Was this patient genuinely hyperventilating, or was the specimen exposed to a massive room air bubble?
Both scenarios produce the exact same error profile. Specimen integrity, physically looking for air bubbles or microclots in the syringe, must be verified by the tech to rule out a pre-analytical error before reporting those critical values.
And that brings us to the final hurdle where all these numbers collide. The clinical chemistry calculations, sections 17 and 18. These are the formulas you must have memorized cold for the boards. No cheat sheets, no app calculators. Imagine a blank whiteboard in front of you.
First, the anion gap. The fundamental formula is sodium plus potassium minus the sum of chloride plus bicarbonate. It essentially measures the mathematical difference between unmeasured anions and unmeasured cations in the serum. A high anion gap is clinically critical. It indicates a severe metabolic acidosis. It is typically seen in renal failure, diabetic ketoacidosis, lactic acidosis, or massive poisonings from methanol, ethanol, ethylene glycol, or salicylates.
Next, the BUN to creatinine ratio. As we mentioned, normal is 10 to 20. A massive increase with a normal creatinine points to a prerenal issue, like heart failure or severe dehydration.
Then there's creatinine clearance, which evaluates the glomerular filtration rate. The formula is urine creatinine multiplied by urine volume in milliliters per minute, divided by plasma creatinine, and finally multiplied by the standard body surface area correction of 1.73 over the patient's BSA.
The absolute critical board trick here is that the volume must be in milliliters per minute. If they give you a 24-hour total volume in milliliters, you must divide it by 1,440 minutes before plugging it into the equation.
We also have the Friedwald formula for calculating LDL cholesterol. It is total cholesterol minus the sum of HDL plus triglycerides divided by 5. The absolute limit here is that this formula becomes completely invalid mathematically and biologically if the patient's triglycerides are over 400 milligrams per deciliter, as the VLDL estimation breaks down.
We also have the osmol gap. This is the measured osmolality from the osmometer minus the calculated osmolality. The calculated formula is 1.86 times sodium plus glucose divided by 18 plus BUN divided by 2.8.
The osmol gap is the ultimate detective calculation. A normal gap is 0 to 10. If it's over 10, there's a hidden ghost in the blood. It means there is an unmeasured, osmotically active solute circulating like antifreeze, ethylene glycol, or rubbing alcohol, isopropanol.
Finally, Beer's law for manual spectrophotometry calculations.
Right.
The concentration of the unknown equals the absorbance of the unknown divided by the absorbance of the standard, all multiplied by the concentration of the standard.
Let's run out loud math on the test. A manual glucose assay shows a patient absorbance of 0.4. The standard absorbance is zero point 0.2, and the standard concentration is 100 milligrams per deciliter. Think about it. What is the patient's concentration?
200 milligrams per deciliter. According to Beer's law, 0.4 divided by 0.2 equals 2. Multiply that by the standard concentration of 100, and you get 200.
Final calculation scenario. Total cholesterol is 250, HDL is 50, and triglycerides are 150. Take a second. What is the calculated LDL using the Friedewald formula?
170 milligrams per deciliter. Triglycerides of 150 divided by 5 is 30. Add that to the HDL of 50 to get 80. Subtract 80 from the total cholesterol of 250, and you are left with 170.
Beautiful. You've got the data. Now it's time to put it to work. We've covered a massive amount of ground today, from the fundamental shifts of SI units all the way through the amperometric mechanics of the Clark electrode.
The key is to trust your preparation. If you understand the underlying mechanisms, why the enzyme kinetics behave the way they do, why the EDTA chelates the calcium, why the air bubble alters the pH, you can deduce the answer to any convoluted scenario the board throws at you. You don't have to just blindly memorize. You have to understand the chemistry.
We talked earlier about how a low specific gravity and creatinine flag a substituted urine in toxicology screens. But think about this. As analytical methods like tandem mass spectrometry and chemiluminescence become infinitely more sensitive, the biological window for what constitutes normal human urine shrinks to a highly specific, personalized cellular fingerprint. The cat-and-mouse game of toxicology evasion isn't just biology anymore. It is purely a high-stakes chemistry problem. The machines are getting too smart, and the algorithms can detect the absence of trace physiological metabolites that no synthetic urine can replicate. Something to mull over as you walk into the testing center.
You've put in the hours, you've drilled the pathways, and you know the reactions.
Go crush the ASCP MLS board exam. We'll see you on the other side of the certification.